Welcome to Pediatric Case Review. Today we present a comprehensive lecture on rickets, covering clinical presentation, diagnosis, and management through interactive case-based questions. This lecture is designed for healthcare professionals seeking to enhance their clinical knowledge. Let us begin our learning journey. Case 1. An 18-month-old child presents with delayed walking and irritability. Parents report excessive scalp sweating and poor feeding. The child was exclusively breastfed with minimal sun exposure. Question: what is the most likely early sign of rickets in this patient? Option A, craniotabes. Option B, bowing of legs. Option C, seizures. Option D, fractures. The correct answer is A, craniotabes. This refers to softening of the skull bones, creating a ping-pong ball sensation when palpated. It results from defective mineralization of membranous bones and typically appears within 3 to 6 months of vitamin D deficiency. Craniotabes is one of the earliest clinical signs of rickets, often preceding limb deformities. Case 2. A 2-year-old child presents with bow legs and wrist swelling. Examination reveals bilateral genu varum. The wrists show knobby enlargement bilaterally. Question: what is this characteristic wrist finding called? Option A, carpal tunnel syndrome. Option B, ricketic rosary. Option C, ricketic wrist. Option D, epiphyseal dysplasia. The correct answer is C, ricketic wrist. This finding represents enlargement of the distal radius and ulna metaphyses, creating visible and palpable swelling at the wrist joints. Similar metaphyseal widening occurs at the ankles and knees. These changes are typically bilateral, painless, and easily detected on physical examination in active rickets. Case 3. A 15-month-old with recurrent respiratory infections is examined. The physician notes a beaded appearance at the costochondral junctions with palpable nodules along the anterior chest wall. Question: what is this clinical finding termed? Option A, pectus carinatum. Option B, ricketic rosary. Option C, Harrison groove. Option D, pigeon chest. The correct answer is B, ricketic rosary. This finding involves enlargement of the costochondral junctions, typically from ribs 4 through 8, creating a beaded or rosary-like appearance. It results from cartilage overgrowth with inadequate mineralization. The ricketic rosary is a classic physical examination finding indicating active rickets in children. Case 4. A 3-year-old child who began walking at 20 months presents with lateral bowing of the tibias. The deformity becomes more pronounced with weight bearing. Question: what is the expected lower limb deformity pattern in this child? Option A, knock knees or genu valgum. Option B, bow legs or genu varum. Option C, flat feet. Option D, toe walking. The correct answer is B, genu varum or bow legs. In rickets, softened metaphyseal bone bends outward under the child's weight during ambulation. This deformity is most common in early walkers with active rickets. The bowing is typically bilateral and progressive with continued weight bearing, but can reverse with appropriate vitamin D treatment and bone remineralization. Case 5. A 2-year-old diagnosed with rickets presents with delayed tooth eruption. Parents are concerned about dental development. The child has only 4 teeth at 24 months of age. Question: what is the expected dental finding in this patient? Option A, enamel hypoplasia. Option B, early tooth loss. Option C, dental caries only. Option D, normal dentition. The correct answer is A, enamel hypoplasia. Rickets affects tooth development through impaired calcification of the enamel matrix. Clinical manifestations include delayed tooth eruption, weakened enamel structure, and increased susceptibility to dental caries. Both primary and permanent dentition may be affected. Early vitamin D supplementation helps prevent these dental complications in at-risk children. Case 6. A 9-month-old infant presents with irritability and muscle spasms. Laboratory testing reveals a serum calcium level of 6.5 milligrams per deciliter. The child was exclusively breastfed and has dark skin pigmentation. Question: what is the most concerning neuromuscular complication? Option A, hypocalcemic seizures. Option B, muscular dystrophy. Option C, peripheral neuropathy. Option D, cerebral palsy. The correct answer is A, hypocalcemic seizures. Severe vitamin D deficiency causes profound hypocalcemia, reducing ionized calcium levels and increasing neuronal excitability. Clinical manifestations include tetany, carpopedal spasm, laryngospasm, and generalized seizures. This is a medical emergency requiring immediate intravenous calcium replacement followed by vitamin D supplementation and monitoring. Case 7. An 18-month-old child has difficulty standing independently. Parents report the child sits with a rounded back posture. Developmental assessment reveals delayed motor milestones. Question: what is the expected muscle examination finding? Option A, spastic paralysis. Option B, proximal muscle weakness. Option C, distal weakness. Option D, normal muscle strength. The correct answer is B, proximal muscle weakness. Vitamin D deficiency impairs muscle calcium homeostasis, leading to proximal myopathy. Clinical manifestations include hypotonia, delayed motor milestones, and waddling gait. The weakness predominantly affects hip and shoulder girdle muscles. Motor function improves significantly following vitamin D repletion and restoration of normal calcium levels. Question 8. Let us explore the pathophysiology of rickets. What is the primary action site of active vitamin D, also known as calcitriol? Option A, bone only. Option B, intestine, promoting calcium absorption. Option C, kidney, promoting phosphate excretion. Option D, liver, producing bile acids. The correct answer is B, promoting intestinal calcium absorption. Active vitamin D or calcitriol binds to nuclear vitamin D receptors in intestinal cells, increasing production of calcium-binding proteins. This enhances absorption of both calcium and phosphate from the diet. Additional actions include regulation of bone remodeling, parathyroid hormone suppression, and immune system modulation. Case 9. A child diagnosed with rickets has an elevated parathyroid hormone level. Serum calcium is at the low normal range, and phosphate is decreased. Question: why is the parathyroid hormone elevated in this patient? Option A, primary parathyroid tumor. Option B, compensatory response to hypocalcemia. Option C, laboratory error. Option D, unrelated thyroid disorder. The correct answer is B, compensatory response to hypocalcemia. When vitamin D deficiency reduces calcium absorption, serum calcium drops, triggering parathyroid hormone secretion. Parathyroid hormone mobilizes calcium from bone, promotes renal calcium retention, and increases urinary phosphate excretion. While this maintains serum calcium, it depletes phosphate and promotes bone resorption, worsening skeletal mineralization defects. Question 10. What is the primary growth plate abnormality observed in rickets? Option A, premature closure. Option B, widening with disorganized chondrocyte. Option C, narrow growth plate. Option D, absent growth plate. The correct answer is B, widening with disorganized chondrocyte. In normal bone development, chondrocyte undergo orderly maturation and calcification at the growth plate. In rickets, deficient mineralization causes unmineralized osteoid to accumulate, creating widened, irregular, and mechanically weak growth plates. These changes appear on radiographs as cupping, fraying, and widening of the metaphyses. Case 11. A child is suspected of having rickets and requires initial laboratory investigation. Question: what is the most appropriate first-line laboratory test to confirm vitamin D deficiency? Option A, bone biopsy. Option B, genetic testing. Option C, serum 25-hydroxyvitamin D. Option D, parathyroid hormone only. The correct answer is C, serum 25-hydroxyvitamin D. This test is the best indicator of total body vitamin D stores and reflects both dietary intake and sunlight exposure. Levels below 20 nanograms per milliliter indicate deficiency, while severe deficiency is defined as levels below 12 nanograms per milliliter. This is the most appropriate first-line test for suspected nutritional rickets. Case 12. A child has confirmed vitamin D deficiency rickets. Question: what is the expected pattern of serum calcium and phosphate levels in this patient? Option A, both elevated. Option B, calcium low, phosphate low. Option C, calcium normal or low, phosphate low. Option D, both normal. The correct answer is C, calcium normal or low with low phosphate. Serum calcium is often maintained in the low normal range through compensatory parathyroid hormone secretion. However, phosphate levels are consistently decreased due to parathyroid hormone-driven renal phosphate wasting. In severe cases, hypocalcemia may occur, increasing the risk of tetany and seizures. Case 13. A patient with rickets has an alkaline phosphatase level of 800 units per liter. The normal range is 150 to 400 units per liter. Question: what does this elevated alkaline phosphatase indicate? Option A, liver disease. Option B, increased osteoblast activity. Option C, kidney dysfunction. Option D, infection. The correct answer is B, increased osteoblast activity. Elevated alkaline phosphatase in rickets primarily reflects bone-specific alkaline phosphatase released by active osteoblasts. This indicates high bone turnover and remodeling as the body attempts to mineralize defective osteoid. The level correlates with disease severity and decreases toward normal with successful vitamin D treatment and bone healing. Case 14. A wrist X-ray is obtained for a child with suspected rickets. The radiologist notes metaphyseal changes. Question: what is the classic radiographic finding in rickets? Option A, fracture. Option B, cupping and fraying of metaphyses. Option C, increased bone density. Option D, joint dislocation. The correct answer is B, cupping and fraying of the metaphyses. These changes represent widening and irregularity of the growth plate with loss of the sharp zone of provisional calcification. Additional findings include generalized osteopenia and decreased bone density. The most prominent changes are typically seen at the wrists, knees, and costochondral junctions, making these ideal sites for radiographic assessment. Case 15. Lower limb X-rays are performed on a 3-year-old child with rickets. Question: what is the expected finding in the long bones? Option A, increased cortical thickness. Option B, bowing with thin cortices. Option C, normal appearance. Option D, multiple fractures. The correct answer is B, bowing with thin cortices. The softened, poorly mineralized bone bends under normal mechanical stress and weight bearing. The cortices appear thinned on radiographs due to inadequate mineralization. Common patterns include anterior tibial bowing and femoral bowing. In severe cases, looser zones or pseudofractures may appear as lucent lines perpendicular to the cortex. Case 16. An 18-month-old child is diagnosed with vitamin D deficiency rickets. Serum calcium is 8.2 milligrams per deciliter and phosphate is 2.5 milligrams per deciliter. Question: what is the initial treatment? Option A, surgery. Option B, vitamin D supplementation. Option C, growth hormone. Option D, bisphosphonates. The correct answer is B, vitamin D supplementation. Standard treatment involves 2,000 to 6,000 international units of vitamin D daily for 8 to 12 weeks. Alternatively, older children may receive 50,000 international units weekly. Supplemental elemental calcium at 500 milligrams daily is also recommended. Laboratory monitoring should occur at 3 months to assess biochemical response. Question 17. Why is calcium supplementation added to vitamin D treatment in rickets? Option A, calcium prevents vitamin D toxicity. Option B, it ensures adequate substrate for bone mineralization. Option C, calcium replaces vitamin D. Option D, there is no benefit. The correct answer is B, ensuring adequate substrate for bone mineralization. When vitamin D treatment begins, calcium absorption increases and bone healing accelerates, dramatically increasing calcium demand. Without supplemental calcium, hypocalcemia may occur during rapid remineralization, a phenomenon called hungry bone syndrome. Providing 500 to 1,000 milligrams of elemental calcium daily prevents this complication. Case 18. A child has been receiving vitamin D therapy for 6 weeks. Question: what is the best indicator of treatment response in rickets? Option A, weight gain. Option B, alkaline phosphatase normalization. Option C, improved mobility and decreasing alkaline phosphatase. Option D, X-ray changes only. The correct answer is C, improved mobility with decreasing alkaline phosphatase. Clinical improvement in muscle strength and mobility appears within 2 to 4 weeks. Alkaline phosphatase begins decreasing toward normal, while calcium and phosphate levels normalize by 3 months. Radiographic evidence of healing becomes visible at 6 to 12 weeks. Combined clinical and biochemical improvement best indicates successful treatment response. Question 19. What does STOS therapy for rickets involve? Option A, daily low-dose vitamin D indefinitely. Option B, a single high dose of vitamin D ranging from 300,000 to 600,000 international units. Option C, calcium supplementation only. Option D, surgical intervention. The correct answer is B, a single high dose of vitamin D. STOS therapy involves administering 300,000 to 600,000 international units as a single intramuscular or oral dose, depending on age. This approach ensures compliance and is useful in settings with limited healthcare access. Monitoring requirements are similar to daily therapy. However, repeat dosing too early risks vitamin D toxicity and hypercalcemia. Case 20. A 5-year-old child with treated rickets has persistent severe leg bowing after completing 6 months of vitamin D therapy. Question: when is orthopedic surgery considered for rickets? Option A, immediately at diagnosis. Option B, after medical therapy fails to correct severe deformities. Option C, it is never needed. Option D, before vitamin D treatment. The correct answer is B, after medical therapy fails to correct severe deformities. Orthopedic surgery is only considered after complete biochemical healing has occurred with vitamin D treatment. Indications include severe residual deformity affecting ambulation or function. Surgical procedures such as corrective osteotomy are typically delayed until near skeletal maturity to prevent recurrence during active growth. Question 21. What is the recommended vitamin D supplementation for exclusively breastfed infants to prevent rickets? Option A. Supplementation is not needed. Option B. 400 international units daily from birth. Option C. Only if the infant becomes symptomatic. Option D. 100 international units weekly. The correct answer is B. 400 international units daily from birth. Breast milk contains insufficient vitamin D to prevent deficiency. Universal supplementation is recommended for all breastfed infants, continuing until the infant consumes adequate vitamin D fortified formula or foods. Infants with dark skin pigmentation or limited sun exposure have particularly high risk and absolutely require supplementation. Case 22. An infant with rickets develops sudden irritability and muscle twitching. Serum calcium level is 5.8 milligrams per deciliter. Question: what is the most urgent complication requiring immediate treatment? Option A. Bone fracture. Option B. Seizure from hypocalcemia. Option C. Infection. Option D. Growth delay. The correct answer is B. Seizure from hypocalcemia. Severe hypocalcemia causes increased neuromuscular excitability, manifesting as tetany, carpopedal spasm, and potentially life-threatening seizures. Emergency treatment involves intravenous calcium gluconate 10% solution at 1 to 2 milliliters per kilogram, administered slowly over 10 minutes with continuous cardiac monitoring. This is followed by maintenance oral calcium and vitamin D therapy. Case 23. A child with severe rickets has a serum calcium level of 6.0 milligrams per deciliter. Question: what is a potential cardiac manifestation of severe hypocalcemic rickets? Option A. Hypertension. Option B. Dilated cardiomyopathy. Option C. Bradycardia only. Option D. There are no cardiac effects. The correct answer is B. Dilated cardiomyopathy. Chronic severe hypocalcemia impairs myocardial contractility and can cause dilated cardiomyopathy. Clinical manifestations include heart failure symptoms and cardiac arrhythmias. Electrocardiogram may show prolonged QT interval. Fortunately, cardiac function usually improves significantly with correction of calcium levels and vitamin D supplementation, though severe cases may require cardiac support temporarily. Case 24. A 2-year-old child with untreated rickets has height measurements below the 3rd percentile. Question: what is the mechanism of growth failure in rickets? Option A. Growth hormone deficiency. Option B. Impaired endochondral ossification. Option C. Malnutrition only. Option D. Genetic short stature. The correct answer is B. Impaired endochondral ossification. Rickets directly affects the growth plate, causing defective mineralization of the cartilage matrix. This impairs the normal endochondral ossification process, slowing longitudinal bone growth. Additional contributing factors include muscle weakness and decreased physical activity. Significant catch-up growth typically occurs when treatment is initiated early, especially before age 3 years. Case 25. An infant with rickets experiences recurrent pneumonia. Physical examination reveals a Harrison groove on the chest wall. Question: what is the mechanism of respiratory complications in rickets? Option A. Immune deficiency. Option B. Chest wall deformity impairing ventilation. Option C. Aspiration only. Option D. Allergies.